Support Outreach Team. Welcome to the Behavioral Support Rounds with CLRI and Baycrest. Today's title is Behavior After Brain Injury, What's Function Got to Do with It? So I'm just going to flip to the next slide here and we'll go through some acknowledgement and land acknowledgement. Although we are meeting virtually, we acknowledge that Baycrest and our related Toronto Central area behavior support programs operates on the traditional territories of many Indigenous nations, which have cared for the land for thousands of years, including the Anishinaabe, Haudenosaunee, and Huron-Wendat peoples. And we recognize that current treaty holders, the Mississaugas of the Credit First Nation. This land remains home to many diverse First Nations, Inuit, and Métis people, and is subject to the dish with one spoon wampum, an agreement to peaceably share and care for the Great Lakes region. We are grateful to have the opportunity to work on this land today. You may live and work in different territories, so we encourage you to reflect on the land on which you are located and to consider your relationships to the land and to the people who are the traditional keepers of the land. I'd like to start by reviewing some basic participation guidelines. This session is being recorded, as you would have already heard, and will be archived on the Ontario CLRI and BSO websites. Your microphone is automatically muted. You will have about 40 minutes or so for the presentation, followed by 15 minutes of discussion and wrap up. Please place any questions at the end of the session using the chat box or the Q&A. If you have questions related to tech support, please message Agnes. So you'll see Agnes with a little dog picture here. For those of you interested in receiving a certificate of attendance, please enter your name and email address in a completed evaluation form that will come afterwards. So I'd like to now introduce our speakers, starting with Nathalie Brown. She is a registered psychotherapist with the College of Registered Psychotherapists of Ontario, board-certified behavior analyst with the Behavior Analyst Certification Board. She's been working with the field of acquired brain injury for many years, in addition to having worked in the fields of autism, developmental disabilities, and dual diagnosis. Michelle Hildebrandt works at West Park Healthcare Centre as a behavior therapist and is a BCBA. Her past experience includes delivering behavioral analytic services to individuals with ASD, teaching ABA-related courses at the post-secondary level, and a BA in gerontology. So thank you so much, Nathalie and Michelle. I will hand it over to you now.
All right, I'm going to share my screen. Go. All right, just see if I can move that over here. All right. Can everybody see the screen? No issues?
Yes.
Perfect. All right. So just move this here.
So we're very happy to have the opportunity with the BSO today to talk about brain injury. You'll notice that in the outline that was sent in regards to the learning objectives, we had listed the function of behaviors first, but we realized, given that the focus of the presentation was about acquired brain injury, we restructured it slightly. So our first learning objective is to recognize how an acquired brain injury may make it more difficult for someone to get their needs met, how that ties in with the functions of behavior, and then common strategies used in rehabilitation that can assist in development of replacement behaviors for the behaviors that you're seeing. And so Michelle's going to start us off with ABI and behavior, and then we'll continue on from there, and I'll pick it up later.
So Michelle, sorry, before you start, if you can put it into presenter mode, somebody asked in the chat box, that would be great.
So I think we did try troubleshooting that, unfortunately, but it does limit me from being able to see my presenter notes, unfortunately. I don't have a secondary monitor, so that part wasn't working for me on my end. I had tried troubleshooting that with Agnes before we had started. Is it too small?
It's okay on my end.
It's fine on my end.
All right.
Just at the bottom where it says 61%, maybe if you click.
How's that? Is that better?
Yes.
Perfect.
Thanks,
Thank
Michelle.
you. No problem. All right. So a little bit about ABI and behavior. So there's a prevalence of challenging behavior after a brain injury, specifically traumatic brain injury, which is roughly about 70 to 80%. These challenging behaviors are often defined as forms of agitation, aggression, or impulsiveness. And on average, the onset of agitated behaviors happens about 14 days post-admission to the inpatient rehabilitation, or about 35 to 80 days post-injury. And so these behavioral concerns may or may not be related to post-traumatic amnesia. There's also a few other brain injury effects that are important to consider that can contribute to behavior. Some of these include the prefrontal cortex or frontal lobe damage, language limitations, new cognitive limitations, changes to sexual functioning, new physical limitations, somatosensory issues, decreased initiation, a lack of insight, increased risk of irritability, depression, and anxiety. And so from taking a look at this from a sort of bird's eye view, we know that there's a lot of changes that happen after brain injury to the thinking, to behavior, and to communication that a person utilizes. But the important part is that these changes need to be combined with the individual characteristics of the person to understand how to help them manage behavior that can result from the changes. So now we're going to talk about the principles of behavior. Oh, sorry, I'm just checking the chat here. Okay. Hopefully it's a little bit better now that it's more zoomed in. So going back to the principles of behavior. So there's a relationship between the environment and behavior. No behavior occurs in isolation. Consistency is key when we're trying to change or manage behavior. And most importantly, paying attention to good behavior increases it, whereas ignoring good behavior extinguishes it. And so there's a strong relationship between parts of the environment and how a client behaves. So, for example, when an agency nurse comes in, often clients act differently than they would with a regular nurse. If a nurse is in a traffic accident on the way to work and is in a bad mood, their behavior will be different temporarily than it usually would be. And by understanding this relationship, you can predict future behavior. So, in other words, why this behavior? Why use it now? And to respond to your client's behavior effectively, it requires you to look at their behavior more objectively and plan your approach. The emphasis of a behavioral approach is to focus on positive, so the behavior that you want to see. And the more attention that you give to your client's good behavior and accomplishments, the more good behavior they will produce. Now we're going to talk about setting events. So setting events include any occurrence that affects a client's responses to reinforcers and punishers in the environment. It can be anything in relation to the environment, the social context, or physiological factors. And these occurrences that affect a behavior at one point in time may change the likelihood of a targeted behavior at a later point. So you can take a look at a headache, for example. If you have a headache and you started off your day with a headache, likely your day might not be the best day ever. You might be more likely to have a low tolerance for stress, a low tolerance for people who are getting on your nerves, and so on and so forth. And so that might change what your behavior looks like on that particular day. But setting events can also be positive. So for example, a person that got a haircut, and you can tell that that haircut makes them feel a lot better about themselves, and it helps them feel better about their appearance. And then if you were to compliment them on it just before you ask them for a favor, you can probably guess that that person is more likely to do you a favor after that setting event was put in place. Context can also be a setting event, though, and people respond differently to the effects of group interactions, the sequencing of tasks and activities, the presence or absence of specific individuals, crowding, and biological factors. So for example, if everyone around me, is arguing, and I'm probably going to be more likely to be argumentative as well. And in terms of the sequencing of tasks and activities, do they go from easier to harder? Non-preferred tasks to preferred tasks? What does that look like? With regards to the presence or absence of specific individuals, we all relate better to the people that we like, and we feel better when someone who supports us is around. Whereas, maybe our behavior might be a little bit different if someone that we don't particularly enjoy is around us. Crowding, for example, this would impede on someone's personal space, their ability to relax, and maybe they might feel the need to get some space to get away from those people who are irritating them. And lastly, biological factors. So things such as, am I healthy today? Am I tall enough to get to that? Do I suffer from depression and now there's been a death? These are all important factors to consider that influence behaviors. So there's a few other ways that we can also identify possible causes for a behavior. One of these are antecedents, and the other is a consequence. Antecedent patterns are really just things that contribute to, for example, a person hitting. If we're taking a look at the behavior of a person engaging in hitting, that could be anything that happened for the behavior. And the consequence patterns are things that happen after the behavior that might maintain hitting as a reasonable solution to the problem for that person. And once data have been collected, ideally, they should be analyzed to determine these patterns. And generally speaking, behavior does form a pattern. The hard part is figuring it out. And so to identify what the behavior looks like when it happens and what behaviors occur in certain circumstances, that can help us get to a pathway of navigating why this behavior might be happening. So the team should use and review observational and interview data to identify any patterns or trends surrounding the problem or the problem behavior. Patterns in this information may suggest that the conditions in which the behavior is most likely and least likely to occur, and it may also help to indicate the potential function of that problem behavior. So now we're going to talk about consequences in a little bit more detail. So consequences are events that follow a behavior. And this can include a positive experience. So this could be a positive experience to the patient, such as increasing the chance that a behavior will occur again. A negative experience, on the other hand, it would decrease the chances that that behavior will occur again. And so these consequences are results of the behavior in the sense of the person either obtaining, avoiding, or losing an item or activity. The consequence can include any event, situation, the behavior of other people, any stimuli, all of which occur after a particular behavior happens. When thinking about consequences, look at your own behavior. A hard day makes you want to give it all up, versus a great day makes you want to come back full of enthusiasm the next day. A consequence is anything pleasant or unpleasant that happens immediately after a behavior. If it is pleasant, the behavior is more likely to occur again. And if it's unpleasant or aversive or painful, it's less likely to happen again. And the only way we can know if something is a reinforcer or a punisher is by an individual's reaction to it. And it's important to remember this principle when we're working with someone, because if you're trying to increase a behavior by rewarding it, and the behavior is not increasing, you might not have something that the person finds reinforcing or reinforcing enough as a reward. If you're trying to decrease a problem behavior and it continues to increase or maintain itself, you might not have an effective consequence to reduce that behavior. And it's important to remember that, what might be pleasant to us might not be pleasant or reinforcing to the client. And what might be unpleasant to us might not be unpleasant to the client. And for this reason, it's so important to understand an individual's preferences when attempting to understand their behavior. So now let's take a look at how we can analyze patterns. So we talked about antecedents and consequences, but how can we use that to help identify patterns in behaviors? The first question we can ask is, what setting does a behavior occur? What time of the day does a behavior occur? Is it more likely to happen in the morning, in the afternoon before lunch, or in the evening, at nighttime before bed? Does a behavior occur in the presence or the absence of a certain person? And in what activity is the behavior least or most likely to occur? And these are all important parts of an antecedent context that we're taking a look at that can help identify what are some things that might be triggering the behavior? What are other factors that need to be considered? Now, if we're taking a look at the consequence or the outcomes of what happens after the behavior has happened, we can ask ourselves, what happens to the client after the behavior? Do the surroundings and the environment change as a result of the behavior? Does a client gain or lose access to something or someone? And how do others respond to the behavior? And these are all really important questions that we should be asking ourselves about the antecedents and consequences associated with a specific behavior in a specific environment. These are questions that lead to understanding the why behind a person's behavior. So let's talk about the functions. Functions of behavior are usually maintained by three big categories of functions. So you've got gaining access to attention or gaining access to a tangible, escaping or avoiding something, sensory or self-regulatory or control of self. So we'll go over these together. So again, just remember that behaviors can be maintained because the client is looking to gain access to either attention or a tangible. So this can be an example of a patient that might yell for help instead of using the call bell because the nurse comes more quickly and starts to spend a long time talking to her about not yelling and using the call bell instead. And so, we might be thinking to ourselves, wait a minute, but the nurse was coming in here to provide her with feedback and tell her that, she shouldn't be yelling, that she should be using the call bell instead. However, that is still a form of attention that we're providing to somebody. Whether it's considered negative attention to us when we're delivering it, the other person might be interpreting it as, positive attention or some kind of interaction that they were seeking. And so what you might see is an increase in that kind of behavior where they continue to yell despite being told to use the call bell instead. Another example of escape or avoidance could be, for example, a client that at the start of every physiotherapy session, they ask to use a washroom. And when they use the washroom, they take a long time to transfer and sit on the toilet for 15 minutes. And this results in the session being terminated frequently. So you might see that if this client who requests to use the washroom has his physiotherapy sessions canceled because his washroom routine takes a significant amount of time, and that results in it being canceled, you might see that this client might be requesting to use the washroom just around the time that physiotherapy sessions begin. And with sensory, for example, a client might wrap the blankets over their head tightly at night to shut out the noise if it's really loud at night, or if there's a lot of beeps or sounds going on in a long-term care home or in a hospital setting. All right, so now I will hand it over to Nathalie.
Right. And so why does function matter? We're looking at the functions because often with our individuals with a brain injury, they have lost some of the skills they had before. They're not able to implement them in the same way they did before. And so they are using lower level behavior to what they might have used in the past because their skill sets are missing due to those potential impacts a brain injury can have that we mentioned in the earlier slide. And so knowing what it is they are trying to achieve can help us help them figure out a replacement behavior to get the same needs met. And often they can't identify necessarily what the function is. And that is why we're looking at doing a full behavior screen and assessment to see what the function potentially is. So when we look at why function matters, we're looking at this competing behavior pathway. We need to consider the function of the behavior problem first before we can teach a replacement behavior. We can develop a replacement behavior that serves the same function as the problem behavior to set them up for an increasing likelihood that they'll be rewarded for engaging in the replacement behavior instead of the problem behavior. Now, one of the questions I sometimes get, though, is, but we're not actually getting the end goal we want, which is for them to, sit quietly, be good. But in actual fact, if we can't find a replacement behavior that matches the same need, then we also can't work towards other skills like learning to wait patiently or using an appropriate voice volume when asking somebody a simple request, those kinds of pieces. So in this example here, we have the setting event, which is somebody's drank a large glass of water, a triggering antecedent, the urgency to urinate. The desired replacement, which might be a long-term objective here, is walking safely to the bathroom. But right now, what they're doing is they're getting out of bed unassisted and they're a high falls risk. That's our problem behavior we're seeing. An alternative replacement would be using a call bell to receive assistance to use the bathroom. Now, usually, the maintaining consequence is that if they get out of bed unassisted and they take a fall, somebody comes quickly and they get to use the bathroom, or they're trying to get to the bathroom as their end goal quickly, and that's why they're not waiting for staff to come. The reinforcing consequence for a desired replacement behavior would also be that they get to use the bathroom safely and quickly. And so in the short term, we're going to teach them to use the call bell, and we have to ensure that we respond quickly to the call bell to help them escape from the unpleasant pressure on the bladder, which is the function of the behavior. We also can work on this long-term objective, which is teaching them again how to walk safely to use the bathroom. But we might have to go through this in-between step to get there. And of course, this is a very medical model of why function matters, but we can also have other models that have to do with other behaviors they might be engaging in that stem from, at times, possibly their aphasia, so not able to communicate in the way they did before, or they're experiencing a lot of setting events that are just making it harder for them to communicate the way they did before, and they are not used to not being able to meet their own needs, because that's something that occurs after a brain injury, where they go from being able to get all their own needs met before their brain injury to after their brain injury due to the injuries or where the damage is not being able to meet them independently without some assistance. So what can we do to help? Can you switch to the next slide, Michelle?
Yep.
So some adjustments we can make due to the sequelae that might be present after a brain injury is we can make sure we repeat information, right? Often people say things once, they assume people heard it, they move on. And after a brain injury, they may be slower to process. They might not hear the information because their attention isn't set where it needs to be to best internalize it. We want to speak clearly at an even pace with pauses between ideas. We want to provide information in a written format, and or for some people, even a supplement with picture support to assist in comprehension if they are able to read. and if they are not, then supporting more with pictures. Offer breaks during tasks because things are often more difficult for them to do than they were before, and they take longer and it can be more draining. And we want to look at working from the client's areas of strength, their physical strength, their cognitive strength, their organizational strength, their emotional strength, and their behavioral strength, because they don't lose everything. It really does depend on where the injury is and how severe the injury was, but sometimes it can be like little pieces are plucked out of the middle of one of their strengths, and they just need to build some of those little pieces back in. And so how do we help with replacement behaviors, and what kind of activities do we need to teach? If we can switch to the next slide, Michelle. We want to look at teaching them how to self-pace, because it can be more exhausting than it was before you engage in activities. One of the things that we do when we're learning tasks is we'll often talk ourselves through tasks. And so sometimes people need to relearn how to talk themselves through a task. And we can also do that again by having the steps to a task written there. We can rehearse specific strategies. So if I am feeling angry today, what are some of the things that I can do? And we practice them. Teaching positive self-statements, because it can be extremely difficult to think of the positives about oneself when one feels like one has lost some of what they had before. Using electronic reminders to help them remember things because of the short-term or long-term memory deficits that can be there. Using calendars and or memory notebooks for those who benefit them. Removing background noise while we're teaching. Using task analyses that the person has a copy of as well as the staff member teaching, and checklists to help them remember what they need for a task. And then teaching using a structured problem-solving approach when you're looking at teaching solutions to problems. So those are some of the strategies we can use after a brain injury. And then the communication strategies to mitigate behavior. We can look at approaching the client on the side of space to which he or she attends to avoid startling them. So sometimes there may be a neglect on one side or the other. You can place materials that you'd like them to see or read in the side of the space, again, to which he or she attends. So if I want somebody to stay in bed and wait for the nurse to come, then I want to make sure that I post my sign that says, please remember to wait for the nurse to come, directly where their eyes are most likely to hit it when they either wake up or when they roll in bed towards the direction to get out. We want to encourage the person themselves to paraphrase any instructions or concepts that you've presented to them to ensure that they actually did have a clear understanding of that, again, because there can be speech and language differences after a brain injury. We want to try to make sure that for really important information, we utilize a simple sentence structure and avoid overly long or complex statements and breaking things down into sections. We want to avoid the use of metaphor or overall abstract language if it's really important for them to internalize the message. And we want to develop a method for interrupting and redirecting clients who are verbose or tangential in their communication. And sometimes that's just developing a cueing system between them and a loved one, or between staff and the client. And we also want to think about if there are deficits in visual perception, that it may be useful to use audio tape recordings in place of written material to help them remember what's been said. Because when we say something once, it disappears, and that's why you guys are recording this webinar so that people can go back and look at it again, because it's easy to forget things when they only occur once. And it's even more difficult to remember them if you have short-term memory issues from a brain injury. And then what can we do to teach those replacement skills that meet the same function? So we can use something called discrete trial training, which is really about breaking a skill down into simple, structured, and attainable steps. And we teach those steps based on where the client starts to have difficulty performing them. So if I was going to give an example of relearning how to tie your shoes, because that is sometimes a skill that disappears after a brain injury, that can be like 24 steps to retying your shoes. And so you might start from step 3, because they can get step 1 and 2 already. They still remember how to do that. That's still automatic, but they get stuck at step 3 and 4. And so we build up to the total steps in the sequence by using trials that not only teach one step at a time, but that the person has mastered those steps before they move on to the next step, or mastered that replacement behavior before you move on to teaching it in a different area or another replacement behavior. And so we use repeated trials or opportunities for that. And that's so that we can actually see if there is success or not, and when we're ready to move on to the next step. We do some prompting to try to create errorless learning and cueing correct responses and then fading the prompts out. And each trial of teaching has a distinct beginning and end. And so what exactly does a discrete trial look like? So it's made up of these 5 parts. And so the antecedent is what happens before you want to see the behavior occur. You then prompt for the behavior. You wait for the response. You provide a consequence for either correct or incorrect responding. You have a set interval between trials, and then you have your criterion to move to the next level. And so criterion can be variable depending on the type of skill. Certainly if it's a safety skill like crossing the street, the criterion to move to the next level would likely be 100%, because if you step out in front of a car, that is a worst case scenario. But criterion to move to the next level on something like tying your shoes might just be 80% across 3 trials. So when you set up a discrete trial, you're going to have an operational definition of the behavior you want to see. So this is an example of using a discrete trial training situation with call bell. And so you can also define when the person needs to use the call bell. And you could even put those reminders up for the person about these are the 4 times when they need to use the call bell to get staff. And then continuing on to the intervention schedule. So you're going to teach them how to use the call bell correctly, including showing them how to recognize the call bell and its location, knowing that they know how to press it, and that they can press it with enough strength to activate it. You're going to post signs with the call bell by their bed, their washroom, and the shower area in order to remind them to use the call bell system. Each morning, you're going to remind them of the needs to use the call bell and what they're using it for. And then you could even set up opportunities for them to practice doing that. And that's the discrete trial piece. The reinforcement procedures are for staff to respond quickly to the call bell. And in this case, in this sort of case example, it was to provide social praise for using the call bell. For other people, it might require an extra reinforcer. And if the patient is asking for something or telling any one of the nurse, therapist, sitter, or family member of a need, then they use prompts and reinforcement procedures to teach them again to use the call bell independently. And you want to use the least amount of prompt required for the patient to be successful when they press the call bell. And then this here is an example of the prompt hierarchy where you're going to choose the least amount of prompts. So visual would be just showing them the sign that tells them to push the call bell. Verbal and a visual is telling them as well as showing them the sign. And then a tactile, verbal and visual is actually assisting them to push the call bell while reminding them they need to push the call bell and showing them the sign that reminds them of this. And then you're going to record the frequency of usage on a data sheet, including what level of prompting you had to use, which trial this is, and was the criteria met for mastery criteria, to decide if it's time to move on to the next step. And of course, another example of using discrete trial training might be making a task analysis of transfers from bed to wheelchair, and then having those steps made up, and again, having the client have a copy of those same steps and working with them to go through. It might just be the first step over and over again until they're successful at 80% across 3 trials. And then we would move on to the next steps until we got to the point where they could successfully transfer from the bed to the wheelchair, and then be able to get themselves out of the room themselves. So those are some samples of ways that we can help someone with a brain injury who's engaging in behavior when we look at functions of behavior in addition to antecedent strategies to help them manage those behaviors. Did anybody have any questions? Michelle has included references for various things that we've talked about today. They're located at the end. Sometimes they're cited during the presentation, and you can feel free to look any of those up as well.
Wonderful. Thank you, Natalie and Michelle. So now is your opportunity to ask any questions. So again, you can use the chat box or the Q&A option, and we'll keep an eye on that. So please ask away. Maybe I can start off with a question that often comes to me from my team. So when we're looking at dementia and responsive behaviors, we're always looking at what's the unmet need. We don't necessarily look at it as an angle of function, but do you see sometimes that there is kind of overlap in terms of that lens of the unmet need and using what's referred to as the pieces theoretical approach, looking at the physical, intellectual, emotional capabilities, environment, and social aspects? Or do you think that there is kind of a clear-cut difference in terms of dealing with somebody with ABI and dealing with somebody with dementia?
So I guess the difference that I would say is often patients with an ABI can be taught and they can retain the teaching with enough repetition. And that's the piece of the discrete trial training. But as far as the pieces models go, the pieces model is also a version of ABA, right? It deals maybe a bit more with the antecedent management of behavior side than replacement skills teaching. And so it's still important to know all those same pieces that you would collect with your pieces model for a patient with dementia. You would still want to know them for a patient with a brain injury. I would just say that sometimes even patients with dementia may engage in some functional behavior. It's probably just that it's more difficult to teach them replacement skills because of the fact that they are not able as easily to learn because the brain is decompensating as you're trying to teach something, right? So the difference would be even a patient, 2, 3, 5 years after a brain injury, if there's been no onset of dementia, can usually still learn. It's just taking the time to break that teaching down. And of course, what you're teaching really has to meet the need as well as what behavior it is they're engaging in. And again, sometimes because of the communication deficits, but other times just because sometimes we honestly don't know why we do some of the behavior we do until somebody says something to us. Hey, I noticed that when you always do this when you're trying to get this done, right? It's really noticeable with some of our patients who were extremely high functioning individuals, that sometimes their acting out behavior comes all around asking for help, because they've never had to ask for help in 20, 30 years. You know, they've been a CEO of a big company. They're used to being the one who provides the help to everybody. And so even identifying that the function of your behavior is actually escaping asking for help because you feel, you know, as an example, you feel weak because you're having to ask for help, but everybody needs help. Even, you know, the staff who are helping you out sometimes need help. And working on how they can say help in a way that feels both comfortable to them and to the other person. And then again, trying to bypass the short-term memory piece. So one of the reasons discrete trial training works so well with ABI is that it ties into the fact that when you are having short-term memory deficits, then the easiest way to lodge learning in somebody is to repeat it often enough that it goes into your procedural memory. And so procedural memory would be the piece where you drive the route you drive to get to work, and you don't remember doing it at the end of the half hour, right? Because you're just doing it on autopilot. Or how many of us think through the steps of tying our shoes anymore, right? We're on autopilot. We're just doing it. And the reason we're just doing it is because we've done it so many times before. We don't actually have to use our active memory or our short-term memory to engage in that behavior. We're just doing it. So one of the things they do in rehab is they work on seeing what is still in people's procedural memory. So how much can you still remember to do of the steps in, say, washing your body or washing your hair? What steps are missing? And then, you know, teaching it. And so it's the same idea. If we practice a replacement behavior over and over and over and over again, eventually it just becomes part of their repertoire, and they're not really actively thinking about it. They're just doing it now. So that would be the piece. It's the ability to still internalize things in procedural memory and to assimilate new learning.
Great, thank you. So a couple of questions have popped up. So hello, Jackie Partnoy. Nice to see you online. So what do you recommend with a person who has difficulty with self-regulation?
So, sorry, Michelle, I'm taking the lead. If you want to pop in and say something, please do.
No worries, sounds good.
So what I recommend is using something that helps them recognize their escalation continuum. So when you look at, you know, what does this look like to other people when I am moving up my escalation continuum from a 1 to, say, a 5? What am I feeling when I'm moving up my escalation continuum from a 1 to a 5? 1 being calm, 5 being I have now exploded and I'm doing my worst behavior, and the other steps being something in between. And then what are some tools I have in my toolbox that help me feel better and come down from that? And then working with staff to, again, practice the skills that help them come down until they become automatic. So things like diaphragmatic breathing, right? Those work for everybody. It could be that people have, you know, they engage in some kind of mindfulness, or they engage in some kind of relaxation strategy. And having those listed in conjunction with our levels of, as I go up my escalation continuum, and then coming up with a cueing system that works for the person and for whoever's supporting them, to help them recognize that they're moving up that ladder before they get to the top, because preventative is always better than reactive, and getting access to those calming strategies before they get up there. And that can be the same whether it's anger, whether it's anxiety. It's a great way to help somebody with self-regulation.
Great. And our very own BSO addiction specialist, Marilyn White Kimball asks, often patients with ABI use substances and post ABI, even low levels of substance use can amplify behaviors. How do you support where there is substance use disorder, i.e. smoking or alcohol?
So just like with every other behavior, there's function to it. For some people, there may be more functions connected. So if I was going to give an example, smoking. I may have started smoking because all my friends were hanging out at the schoolyard and that was the way to be part of the in crowd. So what's the function there? I'm gaining the attention and the time with the in crowd. Then I learned that I like the way it feels. So now I have a sensory component that I have to meet, whether that's holding it in my hands, sucking it in my mouth, or the actual feel of the smoke going into my lungs. And so now we've got two functions going on, right? We have the beginning function that and I continue to smoke because all the other people who go out on smoke breaks at lunch, we hang out together and we have a crowd, right? So looking at, can we meet those functions in some other way? But just like in all cases of substance use, they have to be at the point where they're actually ready to say that they recognize that there is that it is an addiction and that they are interested in changing it. Now there is, Cheers does have the SUBI program, which is substance use after brain injury. And they do a lot of, they've actually got a very nice manual that you can work through as a clinician with a client on trying to cut back on substance use. We talk about other things. It's harder with substances because they give a very powerful consequence. They feel very reinforcing, particularly for people who like to use alcohol or drugs. They give a very reinforcing feeling. And so finding something else that does that can be difficult. If you're working with a physician, there are different solutions that they can assist with, nicotine patches, etc. But there's also, like, if they are already taking something for pain, there are certain pain medications that help more with reducing the cravings for substances. But that alone usually won't be enough. You usually have to look at some replacement behaviors. So how else can I have an in crowd to hang out with where there is nobody smoking? So again, looking at the antecedents, somebody else smoking is likely to be a trigger for me smoking. So really, if I don't want to smoke anymore, I have to be set up in an environment where I'm not exposed to it for quite a while before I'll be successful in abstaining from smoking. And then the other piece is what other activities can I engage in that are not compatible with smoking, so that the more I engage in those, the less likely I am to smoke as well. And then, part of it is the physiological craving, but part of it is actually that there is a functional need met with using substances. But I definitely recommend the Cheers manual for substance use after brain injury for anyone who is looking at trying to help out with that.
Great mention of excellent resources, sounds like. So one of the BSO in-house leads asks, what recourses are available for residents in long-term care with ABI with responsive behaviors and no diagnosis of dementia?
So, right. Responsive behaviors and no diagnoses of dementia. So I guess I would say, when you say recourses, you mean like supports that are available? So there are different, depends on which region you're in. So like we have a behavioral outreach team at West Park that will go out to support. Michelle's one of our clinicians on the outreach team that goes out to support in home, in long-term care settings, in hospital, with assessment to see what the function of the behavior is, and then looking at replacement behaviors that can be put in place. For someone who is having significant difficulty, there is an inpatient unit at West Park. The inpatient unit traditionally has taken people under 65. However, we will look at individuals over 65 on a case-by-case basis. And I say that because, again, we are teaching to replace behavior. And so we need to ensure that there is no diagnosis of dementia. And we do have an ABI day program at West Park. The CODA runs an outreach program as well for individuals who are within their first 5 years of brain injury. And then there's Cheers that has a day program as well, and CODA has a day program as well. Depends on what section of the city you're in. But if you really want to know for certain all the resources available, you would look at the ABI network. The ABI network in Toronto has a list of all the resources that are available in Toronto.
She works in the west end of the city, I can tell you. So Miriam asks, she says, similar to Kara's question, curious about having a diagnosis of behavioral psychological symptoms of dementia with brain injury. Is this common, or should it not be labeled so quickly because with time improvements occur with those behaviors, whereas with dementia, we don't see brain improvements? It's unfortunately progressive.
So yes, I mean, it's sometimes people are labeling as dementia some of the sequelae that comes from the brain injury that the brain may over time learn to reroute. Certainly, if they've been linked with a rehabilitation program, either inpatient or outpatient, and the dementia diagnosis has come from the rehabilitation program, chances are that they have, they've screened and they've actually been trying to teach, and they are aware that they cannot teach in this case. And certainly we shouldn't make the assumption that it's a dementia because they have a brain injury. Would be the best answer I could give to that. It'd be better to have an assessment done perhaps by either a psychologist familiar with brain injury or a psychiatrist familiar with brain injury or a physiatrist that specializes in rehabilitation after brain injury.
Wonderful. Another question came up saying, what is the length of admission to your program?
So the inpatient program at West Park is 6 to 12 months. Yes, 6 to 12 months. Is
there currently a wait list?
Currently not at this moment, although we're reviewing 3 referrals at a time. So I can't guarantee how long I can say not at this moment.
And for Michelle's outreach team, is same question, is there a wait list?
So in terms of the outreach team, I think in terms of at least CODA's outreach team, because I also support the CODA program, as of right now, there is no wait list. And then in terms of the outreach team for West Park as well too, Nathalie, if you want to speak on that, I think you're more privy to that information than me.
Yeah, it usually is somewhere between 2 to 6 weeks for outreach team currently.
Great. So we have just a few more minutes left. Any other questions from the group? Give some time in case anybody's typing. Yeah, I don't think there's any other more questions. So I'd really like to thank everyone for joining us today. Thank you to the presenters, of course. Let me just see. Oh, I'm just seeing in the chat box, thanking you also for this informative session. So again, thank you for the presenters for this very useful content. Just a quick reminder that if you would like a certificate of attendance, please complete the brief evaluation survey, which will be emailed to you. The recording, again, will be available on the Ontario, CLRI, and BSO websites. And once again, thank you for joining us today, and thank you to Natalie and Michelle. This was an excellent session today.
Thanks for having us.
Thank you.
Take care.
Bye. Take care.